It gives me great pleasure to co-chair this session with Professor Alia Abdurabbu. And before starting, I'd like to thank the Bronchology Society for this very nice meeting and for inviting me to share in this session. It's a great honor to introduce with us Professor Sara Tomasetti, who is an Associate Professor of Pulmonary Medicine, Head of International Pulmonology Unit, Department of Experimental and Clinical Medicine, Careggi University Hospital, Florence, Italy. She has lectures regarding the cryobiopsy, lung and mediastinal approach for the diagnosis of thoracic diseases, cryotherapy in pulmonary medicine session, ILDs, progressive fibrotic phenotype, and this is the name of the session, the presentation that she will deliver now, interstitial lung disease session. So may I introduce Professor Sara? Go ahead.
Good afternoon. Thank you very much for your invitation and for your introduction. The first lecture is about fibrotic phenotype, particularly focusing on the recently defined progressive fibrotic phenotype. Let's see what is disease progression and why it is important. Well, it is important because we have been known for more than 20 years then that whatever subtype of fibrotic interstitial lung disease you have, when you get a progression that was defined in the past as decline in FVC more than 10%, decline in the LCO more than 15%, then you get a worse prognosis. So it's like the follow-up of your patient and defining the progression helps you out to discriminate patient with different natural history, and so patient that can be managed just watching from patient that need a more aggressive treatment. But there are some caveats using only pulmonary function looking at disease progression, trying to stratify this patient. First of all, this is a study from idiopathic pulmonary fibrosis, but we can easily apply this also for the other fibrotic non-IPF diseases. An initial decline doesn't always, means in the single patient a subsequent decline. So you can have a huge variability between patients in natural history. Second concept is about using pulmonary function decline as a surrogate endpoint for mortality, because this is what we have in mind, right? So we want drugs that allow our patients to live longer, but we cannot perform mortality studies because we don't have enough number in rare diseases. So we use FVC decline. And we know that FVC decline is a good surrogate endpoint, but as a surrogate endpoint, it works well when there is a direct effect to the final endpoint, that is mortality. This is not always the case in interstitial lung disease because patients can die from other intermediate events. So be careful when you see a progression, a so-called progression, because that decrease in pulmonary function can in fact reflect something else. So respiratory deterioration can be related to pulmonary hypertension, infections, acute exacerbations, lung cancer. So there are many other factors, some treatable, some not treatable, that can influence patient's natural history. And this is something that we should have in mind. So pulmonary function is one piece of the puzzle, but doesn't tell us the whole story. Where are we defining the FVC thresholds? Where there is a nourished literature, and so far we can say that a 5% threshold, at least as seen in clinical trials, does make the minimally clinically difference to detect early a disease progression. And this is why the recent guidelines have used this criteria, and they propose to define progression when there is an absolute decline above 5% of FVC, above 10% of DRCO, combined with clinical worsening or radiological worsening. So now we have new, just published progression criteria. But let's try to focus on what we do have here. This is not a phenotype, okay? Progressive fibrotic ILD is not a diagnosis because it is agnostic to the underlying condition. It doesn't take into account what we're talking about. It is not a phenotype because progressive fibrotic ILD can be CTD ILD, can be HP, can be idiopathic NSIP. So these are all different entities with different biological rationale, different biological implications, and different clinical phenotypes. This is something that this guideline doesn't really acknowledge. And the guidelines says that the criteria that they established are associated with prognosis. And this is true. We see that from the literature. But we don't know whether they are associated also to treatment response. Okay? So, and I will just mention, looking on the definition of progression, what are the criteria of progression used in clinical trials? These are associated with treatment response. So this is just an introduction, trying to confuse your ideas, because oversimplifying things in this field is not useful to manage correctly your patients. So you need to make distinction. You cannot pull all your patients together in the category of progressive disease to make appropriate treatment decision. To make treatment decision, you need to understand what is the endotype, because the phenotype of your disease, meaning the clinical, radiological, and pathological spectrum that you see in the specific patient, depends on the biological factors that are underlying. And this is the picture that you need to have in mind to prognosticate what will happen to your patients. Of course, in terms of prognosis, yes, these criteria are useful because, as I have shown you, if they have a decline, then they will have a worse prognosis. But in terms of treatment decision, the criteria per se are not useful because you need to make your treatment decision taking into account not only the prognosis, but also the phenotype of your patients. And unfortunately, we're not taking into account endotype. Oncologists do, but we will probably do in the future when we will have target treatment. And of course, today I will focus on phenotypes, and I will not mention all other factors that influence the physician decisions: patient's age, comorbidities, specific intolerance to drugs, costs, availability of drugs, which is not the same all over the world. So there are several factors influencing our treatment choices. But let's focus on a progressive fibrotic phenotype. Well, this could be my last slide because progressive fibrotic phenotype really does not exist. But we have several progressive fibrotic phenotypes. So let's mention some of them. We have in mind this when we know something about interstitial lung disease. We know that we have inflammatory-driven interstitial lung disease that respond very well to steroids and immunosuppression, and purely fibrotic. This is IPF with a UIP pattern. It is not really a fibrosis, it's more a neoproliferative disorder where you have proliferation of the bronchioles with depth of the alveolar space, the position of fibrotic tissue, and this is mostly senescence driven. In this setting, immunosuppression is detrimental, is toxic for your patients, and you need to use antifibrotic. Is the only weapon that you can use. And you will have a lecture on IPF treatment, so I will not expand on that. Today we will see what is in the middle. And in the middle, you have a spectrum of interstitial lung disease where you have various degrees of inflammation and fibrosis. And this encompasses fibrotic OP, fibrotic NSAP, HP, connective tissue disease, and you will have a lecture after mine, fibrotic sarcoid even, which is a completely different entity with different treatment strategies. These are some of the interstitial lung disease that we encounter more frequently in our clinical practice. IPF is the black line. It still has the worst prognosis, even if we treat the patient with the antifibrotic treatment. And then we have some very benign form of mild fibrosis, in particularly, for example, smoking-related ILD. We didn't have any death at 8 years. Of follow-up, and then some intermediate entities such as NSAP and HP, which are very frequently encountered in clinical practice. I believe in this country, HP has a very high incidence. I see that you publish many more papers than we do. And so today I will try to focus mostly on the progressive phenotypes of these two disorders. Idiopathic NSAP is an entity that was discovered by chance on histology, characterized by various degrees of inflammation and fibrosis that do have a uniform appearance, temporal and spatial uniform appearance. Clinically, is a disease of the women. There is a clear association with autoimmunity. Idiopathic NSAP patients tend to develop autoimmune features or full-blown autoimmune disease. And when you have autoimmune features, such as in IPF or autoimmune disease, you have a better prognosis compared to the idiopathic form. So the first prognostic determinant is the clinical scenario. Take that into account. Secondly, you have a great heterogeneity in NSIP, also from a radiological point of view. You can have NSIP-OP, which is the form that tends to respond better to treatment, and you can have highly fibrotic forms of NSIP. Here, the treatment response is a little bit more tricky. And of course, the radiologic heterogeneity mirrors the histological heterogeneity that encompasses cellular NSAP, which is the inflammatory form, and fibrotic NSAP, which is the most fibrotic form. And NSAP can be associated with other histological patterns. Does it matter? Yes, it does. Because depending on the association, so on histological information, you have a different response to immunomodulation and steroid treatment. So this is also important when you want to define your progressive phenotype. Why is this? I mean, this is a genetic study that is showing us that IPF is clearly a senescence-driven disease where you virtually have no gene expression related to inflammation. And then you have this beautiful NSAP, which is exactly the contrary. Here, the genetic pathway is toward the expression of inflammation and the T-cell recruitment, and virtually nothing on cell senescence. But in fact, in reality, you have also intermediate cases. Patients in which you have a combined molecular mechanism, these cases do express inflammation genes, but they also do express genes that overlap with that of IPF. So just trying to send you the idea that within NSIP you have different phenotypes and different endotypes, and in some phenotypes you can have the molecular similarities to IPF, even if you do not have the typical UIP pattern. And genetics tells that to us. If you have a telomeropathy, a genetic mutation, then it doesn't really matter if it is IPF or NSIP, because your prognosis, the prognosis of the patient, will be poor in any case. In terms of disease behavior classification, NSIP is very heterogeneous for the reason that I've told you. So you can have reversible disease, disease that respond to treatment and remain stable, and then you can have progressive disease that after immunosuppression, after appropriate treatment, doesn't respond, it doesn't stabilize, and continue to progress. This is the subgroup of cases that you should select for antifibrotic treatment. And in NSIP, we have two different phenotypes that I think this paradigmatic distinction is very useful in clinical practice. We have the prototype of OP-NSIP, which is characterized by OP-NSIP pattern both on radiology and on histology, and by lymphocytosis and BAL and acute subacute onset. The typical CTD that has this pattern is the antisynthetase syndrome, that we can consider the pathognomonic form. But also in idiopathic cases of NSIP, you can have this phenotype. And this is the phenotype that responds better to immunomodulation. So probably you will not need to use antifibrotics in this patient if you diagnose and treat them timely with the immunosuppression. On the other side of the spectrum, you have truly fibrotic progressive NSIP, chronic onset, traction bronchiectasis, no lymphocytosis on BAL, only fibrosis in biopsy. The prototype, if we think of connective tissue disease, is scleroderma-related NSIP, which often has this relentlessly progressive phenotype. And these are the cases that may not respond properly to immunomodulation and in which antifibrotic may be useful. These are some of the elements that we take into account when we make our treatment decision. And similarly for fibrotic HP, which is a T-cell driven disease, we have different phenotypes that reflect radiologic presence of fibrosis, different genetic and functional different diversity of expression in T-cell mediators. The fibrotic form, again, is without lymphocytosis, is the one, and with UIP pattern particularly, is the one that declines more. And histology, again, is helpful to refine prognostic subgroups based on different patterns of HP. In this disease, the approach is completely different. So avoidance of the antigen exposure can be useful to stabilize disease in 1/4 of patients. So it's very important. And this is the Egyptian contribution to the field. Very important. Don't forget your steroids. Very cheap drug, very effective. And they've shown that, of course, it is effective more in non-fibrotic HP, but it has some effect also in fibrotic HP. This is correct because the pathogenesis of this disease is inflammatory driven, so this makes a lot of sense. And then these are the Portuguese that are telling us that when you have lymphocytosis on BAL, the chances to have a better favorable response to azathioprine are higher. And this is genetic. Again, when it comes to telomeres, if you have short telomeres, you will get a worse prognosis, a worse response to immunosuppression. So there are some genetic similarity in subgroup of HP that recall IPF. Let's remember MUC5B and telomere, which are the most important. But in general, fibrotic HP is different from IPF. We have form with a favorable prognosis and better response to immunomodulation, but we also have form with UIP pattern with the low lymphocytes, with advanced disease, with short telomere lengths that will not respond to immunomodulation. And these are the patients that you can select for antifibrotic treatment. I will not talk about treatment. This is just to mention the criteria to select the patient that were included in the InBuild. That are slightly different from current guidelines. The decline of FVC was above 10% or between 5 and 10% combined with symptoms and radiologic progression. Both NSAP and IBF were included in the trial, and of course, nintedanib showed to be effective, such as did pirfenidone in the RELIEF trial. Here, again, both NSAP and HP were included in the trial. They used the 5% decline of FVC, and they showed that, again, also pirfenidone was effective in this progressive disease. So within the end, just remember that immunomodulation in diseases that do have an inflammatory pathogenesis is still a good choice for your patient. If they don't respond, of course, now we have a new drug that we can use, 2 new drugs that we can use, which are antifibrotics. So in conclusion, the appropriate diagnosis of progressive fibrotic ILDs is, for an appropriate diagnosis, it is important to discern which is the entity. And among the specific, after have done the specific diagnosis, you need to understand what is the phenotype of that specific patient, because you have heterogeneity even within the same disease. In the vast majority of non-UIP fibrotic ILDs, and I've shown you 2 examples, NSIP and HP, immunomodulation is still a good choice, and antifibrotic can be used for progressive cases. In UIP ILD, well, we need definitely more data to understand whether immunosuppression is still an option, or whether these patients are more similar to IPF and do deserve antifibrotics since the beginning. But unfortunately, we don't have this data because the trial were not stratified based on histology. And yes, we really do need molecular targets and molecular therapy, because now we're throwing at our patients the drug that we have, which is not exactly a precise approach. Thank you very much.
Thank you very much, Professor Dr. Sara Tomasetti, and a very nice illustrative talk. And in appreciation of your presence with us today, Professor Dr. Tarek Safwat will present this simple trophy for yourself. Thank you very much. Thank you. It's an honor having you with us today. Thank you. And now it's my honor to present Professor Dr. Yusri Al, the head of Chest Department, Cairo University, and his talk will be about the connective tissue disease-related ILDs, when and how to treat. We will be honored with your lecture. And just reminder, we are behind schedule. Professor Dr. Yusri. Okay, thank you.
بسم الله الرحمن الرحيم. دكتور طارق بيه، انا عاوز زي دي يعني وصورة وكل حاجة وسارة تتصور معايا بيه. بسم الله الرحمن الرحيم. Today I will speak about a very hot topic, which is connective tissue disease related ILD. And we have 2 big questions that up till now we don't have a solid answer for them. When to start treatment and how to treat. This is a list of the common connective tissue diseases, but today I will focus on scleroderma ILD because it is the major prototype of this devastating and frustrating diseases. Scleroderma, it is not the commonest rheumatic disease, but it carries the highest mortality rate among all rheumatic diseases. And the main cause of mortality in systemic sclerosis is interstitial lung disease. So, how to suspect the presence of ILD in patients with scleroderma? This is all based upon first symptomatology, then the pulmonary function, spatial spirometry, and DLCO. And you can use lung ultrasound, but the gold standard to rule in or rule out the presence of ILD in connective tissue disease is HRCT. This is the commonest and the most ugly pictures that you can see in patients with scleroderma. This a bad form of fibrotic NSIP, and this is a hugely dilated esophagus. This is the same. This is NSIP. This is NSIP with volume loss and dilated heart and heart failure in patients with scleroderma-related ILD. Regarding these images, all these images are NSIP, and most of them are cellular forms of NSIP, as we don't have any signs of fibrosis. We don't have definite traction bronchiectasis or a little bit of honeycombing, as we see in some cases of NSIP in scleroderma. NSIP is the commonest radiological presentations in all connective tissue disease, and the commonest form of ILD in patients with scleroderma ILD. And the big question is that, can we start the treatment at this early phase, a little bit early phase, where less than 20% of the lung volumes are affected, or should we wait till the criteria that we have a more extensive disease? To me, to start early is much better than to wait for certain criteria to be fulfilled. This is different pictures, and this is overlap case. This is NSIP together with lab in a patient with scleroderma ILD. This is the risk factors that push us to start the treatment. And to me, most of these risk factors are a little bit late. Scleroderma-related ILD represent a form of abnormal wound healing, abnormal response of the lung to injury. And the injury in this case is immune-mediated. From the first days and from the early days in the presumed inflammatory phase, fibrosis sets in, because this is abnormal response of the lung to healing with imbalance between H1 and H2 response. So it is better, we think, to start the treatment earlier than to stay for this rather late phase. This is the high risk factors for progression. Disease duration reflects them for years. Diffuse cutaneous systemic sclerosis, HRCT, the presence of fibrotic phenotypes like the presence of reticular pattern of traction bronchiectasis, reductions in the vital capacity by 1/3 from below normal, which is too big, and also reductions in DLCO less than 50%. The rapid decline over 2 years in the measured lung function. Other factors that carry a worse prognosis and push you to start the treatment: old age at onset, male sex, and regarding the serology, the presence of anti-topoisomerase antibody, which is anti-scleroderma 70. It is one of the antibodies that leads to aggressive lung pathology. Certain biomarkers like KL6, chemokine ligand 18, and the elevated CRP above 6 milligram. Treatment of scleroderma of ILD, when to initiate treatment? This is the first questions, early or late. According to different literatures, You can start a treatment in a scleroderma patient with respiratory symptoms and recent disease onset less than 2 years, but the patient should have respiratory symptoms. Relative declines of vital capacity or total lung capacity more than 10%, or relative declines daily CO more than 15% over 12 months. Extensive ILD involving more than 20% of lung volume in HRCT. To me, all these criteria are lead criteria, and the earlier the better. More than 50% of cases of scleroderma ILD progress. And if you are treating a progressive disease, especially when you detect fibrosis in the HRCT, the outcome will be frustrating. And your idea and your target will change from improving the vital capacity to decreasing the loss in the annual vital capacity. Treatment is that we have immunosuppressants, because it is immune-mediated disease, so the gold standards or the cornerstone, the treatment of systemic sclerosis ILD should be immune suppression, adjuvant low-dose corticosteroids, but please avoid high-dose steroid to avoid renal crisis. These are alternative initial therapy, and the big questions is the maintenance therapy. What is the best agent and for how long? So we have some agents under investigations, supportive treatment, especially you have to control well the reflux, which is a leading cause for progression of the disease, and the lastly, lung transplantation. Regarding immunosuppression, again, cornerstone for the treatment of scleroderma ILD and all connective tissue disease-related ILD, because we are dealing with autoimmune disease. Mycophenolate mofetil is which is the CellCept, is the agent of choice right now in the treatment of most of connective tissue disease-related ILD, according to scleroderma study 2. This scleroderma lung study, one that was conducted about 15 years back, that compares the effect of cyclophosphamide orally daily, 2 milligram per kilogram per body weight daily, versus placebo in scleroderma lung disease. Most of these cases in the lung study 1 have had inflammatory pathology rather than fibrotic pathology based on the HRCT finding and the PAL finding. And the expectation was higher than the actual result that they detect. 1 year of oral cyclophosphamide in patients with symptomatic scleroderma-related ILD had a significant, to me, it is not significant, it's a little bit, and the modest beneficial effect on lung function, dyspnea, thickening of the skin, health-related quality of life. The effect of lung function were maintained through the 24 months of the study. The study was conducted over 2 years. The first 2 years you give the drug, and second year you don't give cyclophosphamide, just continue on other lines of therapy apart from cyclophosphamide. And they detect that 12 months later, following the terminations of cyclophosphamide, the lung functions or the effect of the positive effect of cyclophosphamide waned totally. So we have a maintenance therapy. Scleroderma, but cyclophosphamide is not safe to use it for a longer period because of the cytopenias, immunosuppression effect, and the high risk of hemorrhagic cystitis and cancer bladder. Scleroderma lung study 2 compares the mycophenolate mofetil versus oral cyclophosphamide in a scleroderma-related ILD. They gave cyclophosphamide for 1 year, mycophenolate for 2 years, and the comparable outcome was detected on both groups. And the conclusion from lung study 1 is mycophenolate is well tolerated and have equal efficacy like cyclophosphamide in slowing down the progression or stabilizations of ILD in scleroderma patients. Adjuvant corticosteroid, you can add low-dose steroids, not more than 10 milligram per day, to either cyclophosphamide or mycophenolate, especially glucocorticoids. We usually add glucocorticoids in the maintenance phase of treatment when with mycophenolate or azathioprine. Tocilizumab, it was studied in scleroderma patient in early cases, and the target of the study was the effect of tocilizumab on the skin. The secondary outcome was the ILD. And they found that early use of tocilizumab leads to better stabilizations of interstitial lung disease in scleroderma patients. The dose that used in the study was 162 milligram once every week, given subcutaneously. But the big question for how long can we continue on tocilizumab? Azathioprine, you can use azathioprine in the maintenance phase of treatment of scleroderma ILD following terminations of mycophenolate for any reason, or following terminations of cyclophosphamide. You can use azathioprine together with low-dose corticosteroids. Long-term survival was similar in scleroderma in cyclophosphamide and the placebo group of scleroderma lung study 1. The long-term survival, because we gave cyclophosphamide for only 1 year, and its effect waned over the second year. So it is logic that long-term survival was similar in both groups. Also, the long-term survival was similar in mycophenolate and cyclophosphamide groups of scleroderma lung study 2. And according to scleroderma lung study 2, you can use azathioprine together with low-dose steroid as alternative agent in those who can't tolerate mycophenolate. No enough data till now about the use of tocilizumab as a maintenance therapy in scleroderma-related ILD. But what if your patient experiences progressive pulmonary fibrosis phenotype despite treatment with the above drugs? I'm going to go through these slides. Prof. Sarah discussed it in details. Based on this finding, since trials was conducted to test the efficacy of nintedanib in stabilizing the progressions of ILD in patients with scleroderma. Nintedanib was used with immune suppression with mycophenolate. And according to the result, nintedanib leads to slowing down in the rate of annual loss of vital capacity in those who receive the drug compared to placebo, significant reductions in the annual loss. But the big question is, can we start antifibrotic from the early days of connective tissue disease-related ILD, so long as that we are dealing with abnormal wound healing, pathological response of the lung to injury, and so long it is a pathological response, fibrosis is a must at the end. Why you don't use antifibrotic drugs from the early days together with immune suppression? It's a big question that we have to try to find the answers with a big multi-center trials. Agents under investigation, perfenadone in the scleroderma lung study 3, and also in which is still ongoing study, and also in relief study. Rituximab can be used in refractory cases, and this is, to me, it is a very bad statement. Refractory cases means advanced fibrosis, and rituximab is a good to control the antibody production from P lymphocytes, suppress antibody production from the P lymphocytes. So why you don't use rituximab from the early start? I think the outcome will be much better. Supportive therapy, the most important is smoking cessations, influenza and pneumococcal vaccinations, in addition to control of GERD. If your patient refuses to take any drugs or can't tolerate any drugs, at least control the GERD for this patient. Gastroesophageal reflux play a major role in the pathogenesis of all interstitial lung disease, especially in scleroderma. You can give proton pump inhibitors up to 3 times daily, also prokinetics, and you can go for fundoplications for complete control of GERD. Those who present with dysphagia, you have to use motility therapies and emerging therapy like buspirone. This is regarding the scleroderma-related ILD. And my conclusions for scleroderma ILD, I think we have to start earlier, and we can try the add-on of antifibrotic drugs in the early days of treatment, not to start to more advanced phase and a progressive pulmonary fibrosis phenotypes. As the outcome in most cases is not good with all immune suppressions that we use. Pulse cyclophosphamide, mycophenolate in 3 grams daily, cyclophosphamide orally. All these drugs give a little bit of not improvement, but rather stabilizations of the pulmonary functions in a fraction of patients and not all patients. So we can use all the drugs that we have. We can use antifibrotic drug together with the immunosuppressions from the start. I think this will be answered in the new future. This question will be answered in the new future. I will stop here and thank you very much.
Thank you, Professor Yusri, for this elegant presentation. And now I have the pleasure to introduce Professor Alia Abdurabbu, who will speak to us about the treatment of IPF and PPF.
Dear professors and colleagues, thank you for joining us today, and thanks for the Egyptian Scientific Society of Oncology for inviting me. Now I'm going to talk about the update practice guidelines of management of IPF and PPF. These are the new guidelines just published recently in the American Journal of Respiratory and Critical Care Medicine, and I declare that I have no conflict of interest. To start with, the ATS and the European Respiratory Society, the Japanese Respiratory Society, and the Association of Thoracic Medicine in Latin America, they decided to upgrade the usual guidelines posted in 2018 and updated the definition of IPF and the progressive pulmonary fibrosis. This was a multidisciplinary work using what's called the GRADE approach to answer the following question. About the update of IPF, they will answer what are the radiologic pattern, what are the histopathologic diagnosis, the rule of transbronchial lung cryobiopsy, the rule of genomic classification, the overall diagnostic approach, and the use of antacid and the anti-reflux surgery. And also, they asked about the progressive pulmonary fibrosis. They asked about the definition, the radiologic pattern, the physiologic criteria, and the use of certain drugs. This is the GRADE approach for assessment. If 70% of scientists agreed for this guideline, the guideline will be declared as approved. The first part of the guideline was about the update of diagnosis and treatment of IPF. They said that the cornerstone of diagnosis is the radiologic feature of UIP, but they entered certain things. They said that lung fibrosis can confidently be recognized if we see the traction bronchiectasis with or without honeycombing, and said that take care that honeycombing can occur in can be differentiated from paraseptal emphysema like this one and airspace enlargement like this one, and that the hallmark of UIP, which is honeycombing, can also occur in cases of hypersensitivity pneumonitis and in connective tissue diseases, as Professor Dr. Yusri said. They expanded the definition of cases of UIP to include the pleuroparenchymal fibroblastosis, which are present in 6 to 10% and indicate worse prognosis and lower lung function and more risk for side effects. These are the new categories explaining what are the UIP, what is the probable UIP, what is indeterminate, what is the suggestive alternative diagnosis. To make it easy, if we found anything suggesting alternative diagnosis, the patient will be with an alternate diagnosis, either connective tissue disease or scleroderma or whatever sarcoidosis. If the histopathology is confident more than 90% of UIP, the patient has UIP. If the confidence decreases, the patient must probably have alternative diagnosis. The distribution of the lesion, if it is subpleural and basal lesion, we can easily say that it is UIP pattern or probable UIP pattern. If it is diffuse without any subpleural predominance, it is undeterminate. The presence of cyst, mosaic attenuation, GGOs, micro or macro nodules, consolidation, pleural plaques, and dilated esophagus can easily exclude the UIP. They discussed merging the definite UIP with the probable UIP pattern, but they at last decided to remain the 4 categories said before and said, actually, although the UIP pattern and probable UIP pattern remain separate, they have similar diagnostic approach, similar histologic confirmation, which is unnecessary usually unless there is fear of an alternative diagnosis. The second question was about the histologic features of UIP. They said that UIP can confidently be diagnosed if we have a patchy dense fibrosis with architectural distortion, if we have subpleural and paraseptal lung parenchyma affected, if there is fibroplastic foci, and the absence of the other alternative diagnostic features. If all these features are present, we can confidently say that the patient has UIP pattern. If some of them are present, the patient has probable UIP. The third question was about the use of cryobiopsy in these cases, and the original question was to use the cryobiopsy or surgical biopsy. They compared the diagnostic yield of both cryobiopsy and surgical lung biopsy, which were 80% to 90%, and said that they both have similar diagnostic confidence. They compared the side effects, which were 9% and 6%, and concluded that cryobiopsy is less invasive and less costly. And they compared the contraindication of each of them, and they said that both of them are contraindicated in cases with severe lung function derangement, moderate to severe pulmonary hypertension, uncorrectable bleeding risk, and or significant hypoxemia. And they said that the use of transbronchial lung cryotherapy is very challenging in these cases because of the subpleural placement of the lesion, which make sampling error very easy. So, by cryobiopsy, if we say patchy fibrosis and fibroplastic foci, we can only diagnose a probable cases of UIP. And the recommendation was that the use of cryobiopsy is acceptable alternative of the use of surgical lung biopsy, but only in centers when they have experience of cryobiopsy and experience in histopathology reading. The next question was about whether or not to use the genomic classification testing. And they said that this decision is very immature because of the lack of sensitivity. The sensitivity needs to be improved. The downstream consequences of false negative results cannot be explained. Other results must be obtained to determine precisely the sensitivity and specificity of these tests. And that genomic test didn't add anything to the histopathologic and the high-resolution CT findings, and it didn't correlate very much with the histopathology. And it is important to identify UIP in the context of expanding the antifibrotic indication, and such testing are not yet widely available. And they need more research to prove that. And they make no recommendation for or against the use of genomic testing in cases of IPF. So, to summarize and sum up, the diagnostic approach of cases of suspected IPF, if we have each high-resolution CT pattern of UIP or histologic pattern of UIP, we have definite interstitial pulmonary fibrosis. If we have any alternative diagnosis in histopathology and high-resolution CT, certainly it is not IPF, and we need multidisciplinary discussion in between them. The main approach, the main difference is that cases of probable UIP are now managed similarly to UIP. That means if the patient is not having an alternative diagnosis, if I have chest high-resolution CT with UIP, definite or probable, I will manage the patient directly as IPF. Otherwise, If we are suspecting undeterminate cases, we can do either cryobiopsy or surgical biopsy. As regards the use of antacid, they asked a question whether the use of antacid in patients with IPF with associated gastroesophageal reflux can improve the respiratory symptoms. They examined the disease progression, the mortality, the exacerbation, hospitalization, lung function, and they said that the use of antacid didn't improve neither of them, but they can improve only the gastroesophageal reflux severity. And the recommendation was not to treat patients with IPF with antacids except to control the gastroesophageal reflux manifestation. The same comes for the anti-reflux surgery. It improves only the reflux manifestation but didn't improve any respiratory manifestation. And this is the sum up of the management protocol. We can treat the patient pharmacologically or non-pharmacologically. We can treat the comorbidities and we can control the symptoms. And then we follow up the patient every 3 to 6 months when indicated and treat the exacerbation with corticosteroids and then to plan to lung transplantation. And they said that we need further direction to validate the family history and genetic to avoid any invasive procedure, to evaluate the combination of therapy, and to categorize strategies for addressing the quality of life in these patients. The second part of the guideline was about the diagnosis and treatment of PPF in fibrotic ILD other than interstitial lung disease. They defined these cases as cases having at least 2 of these following 3 criteria occurring within less than 1 year with no alternative explanation. The 3 criteria are worsening of respiratory symptoms, worsening of physiologic criteria, and radiologic evidence of disease progression, as we will say later. They said that progressive pulmonary fibrosis is not a single entity, as Professor Dr. Sarah said. All these shaded areas represent cases of progressive pulmonary fibrosis that can occur in cases of idiopathic interstitial pneumonitis or autoimmune ILDs or exposure-related diseases or diseases with cyst and even sarcoidosis. These cases, all of them, can manifest with progressive pulmonary fibrosis, and the histopathology is diverse in each of them. So, what are the manifestations of physiologic criteria of all these cases if they are presented with progressive pulmonary fibrosis? It includes absolute decline in forced vital capacity more than 5% and absolute decline of DELCO more than 10% within 1 year of follow-up. They said that these criteria should be applied but not during the exacerbation. We should assess the patient for progressive pulmonary fibrosis after the end of exacerbation. What about assessing the patient for progressive pulmonary fibrosis radiologically? They said we can use either visual forms or quantitative forms. The visual form is examining the high-resolution CT, the upper part, the middle, the lower lung zone, as well as in transverse coronal and sagittal section side by side to see any extent of fibrotic lesions. These fibrotic lesions may include traction bronchiectasis, new ground glass appearances, new fine articulations, increased coarseness of already present reticular patterns, or increased honeycombing, or increased loss of lobar volume, as in cases in this patient, where there is increase in the extent of reticular abnormality with evolution of new traction bronchiectasis. It may also include evolution of GGO to reticular abnormality, evolution of reticular abnormality to honeycombing, or increased traction bronchiectasis, and patients with non-specific interstitial pneumonia can present with honeycombing, as in these cases when we can see there is increase in the extent of reticular abnormality and evolution of reticular abnormality, new ones, to honeycombing. They said that we can also use what is called quantitative assessment of progressive pulmonary fibrosis. These are new techniques that are more objective and more reproducible. They use either simple histogram or machine learning methods. They have successfully defined the extent of progressive disease and predicted the mortality, but they need more and more validation. This is a picture of quantifiable cases where the red point here indicates the most affected lobe, and this area indicates what happened in this patient within 1 year when the amount of fibrosis increased from 9% to 14%. And the last question was about the use of certain treatments, the pirfenidone. giving the idea that progressive pulmonary fibrosis can occur in cases of UIP or non-UIP pattern, progressive fibrotic hypersensitivity pneumonitis, connective tissue diseases, non-specific pneumonitis, sarcoidosis, occupational and Langerhans disease. Can we use pirfenidone in all these cases? They studied the outcome as mortality and disease progression and found slight improvement in mortality and disease progression. And they studied the important outcome as lung function, with it result in improvement. Respiratory symptom also improved with the presence of some adverse effects. And the recommendation was that they recommended further research into the efficacy and effectiveness and safety of this drug in cases of progressive pulmonary fibrosis with interstitial pulmonary fibrosis or non-interstitial pulmonary fibrosis. The second drug was nintedanib, and they asked the same question: should we give patients with progressive pulmonary fibrosis, regardless of the cause, this drug? And they measured the mortality and disease progression and found slight improvement in survival and slight decrease in progression, but there is improvement in respiratory symptom with some of acute adverse events. And this suggestion was that this drug can be used in patients with progressive pulmonary fibrosis only who have failed the standard management of fibrotic ILD, and more research is needed to test the efficacy and effectiveness and safety of this drug. And lastly, the further direction was added. They said that there is additional need to include what is called, to determine the reason why some subset of people develop progressive pulmonary fibrosis despite the progressive and rapid initial treatment. There is a need to validate some serum marker or bronchoalveolar lavage marker to predict which patient will progress to progressive pulmonary fibrosis and measure the prognosis of this patient, to validate conventional neuronal network of high-resolution CT and quantitative measurement of fibrosis, and increase the researches related to timing and sequence of the use of antifibrotic drugs in relation to corticosteroids and immunosuppressants. And thank you.
Thank you very much, Professor Alia Abdurabbu, for this updated presentation. And I'd like, before closing, to thank Professor Tariq Safwat, Professor Ashraf Hatem, and Professor Ahmed Halafawi for this sophisticated Congress, and all members of bronchology. I would like to congratulate them all. And now I will introduce our next chairpersons, Professor Amani Omar, Professor Hussein Al-Masri, Professor Layla Ashur, Professor Medhat Nig, Professor Nuran Azab, and Professor Raed El Metwali.